I think you can go ahead and take it away.
Okay, great. Hello, everyone. Thank you for coming to the second Values and Principles work group meeting. This is Jenny Donovan. I'm sorry that you're not going to be able to see me during the presentation, or not really the presentation, during the work group. I just want to put out another reminder, like we did last week, that this work group was started as a place for board members to come together to discuss the values and principles that the board will work through. We will not be taking public comment during this meeting. However, if you would like to submit public comment for the full board meeting where they will take up the recommendations of this work group, you can do so in writing. If you do that, please try and submit 72 hours in advance to give the board an opportunity to review your comments, or you can attend the board meeting and give oral comments in person at the meeting. Either way is just fine. Katie DeLuca, our administrative assistant, can help you with getting to those locations, and they are posted in the materials. We were able, Katie, go ahead and go to the next slide. So we did meet last week. And Debbie, welcome. I know you weren't able to attend last week, so we're thrilled to have you this week. I will do a brief overview of the agenda, and then Katie will call the roll, and then we will get into the discussions. So the agenda for today is, last week there was a question about clarification for the board's role, and so I've added a little bit of information so that we can cover that first. Then we can go back into the discussion that was started last week about the overarching principles. Then have a conversation about any additional principles that the work group would like to recommend to the board, or fleshing out any of the overarching principles into additional principles. And then we will talk about preparing our recommendation on values and principles to the board. Hopefully we can do that in this meeting. There is another meeting scheduled for next Wednesday for this work group, but as we work through today, we'll try to scope it down to make sure that we are capturing any recommendations and see if we have those recommendations by the end. Last week, we were able to have a facilitator step forward, and that is Vice Chair George, and so he will be facilitating today's meeting as well. I will take on the first couple slides, though, about the scope, and then hand it over to Vice Chair George. So Katie, if you'd like to call the roll.
Thank you, Jenny. Chen-Wei Chi?
Present.
Debbie Diaz? She might have lost her audio again, but I do know she's here. Debbie, we'll circle back just to make sure we get our audio good with you. Amy Fellows?
Here, and I think Michelle's trying to hop on.
Oh, perfect. Okay. Warren? George?
Present.
Debbie Diaz, any luck with your audio? Don't you just love technology? All right, I'll circle back with Debbie, but thank you all.
And maybe we could just have Debbie do the raise hand function. Is that available? And that could count her as present for the role.
Can she hear us?
I'm not sure. Debbie, can you hear us?
I don't think so. Okay, I will just reach out to her individually.
Thank you.
Okay, I'm gonna go ahead and move it to the next slide.
I just let Michelle in.
Great, thank you so much.
Okay, and so during the last meeting, there was a question raised during the conversation about what the scope of the board's work. And I brought forward what the enacting legislation for the board was, which is Senate Bill 1089. And in section 2 of that bill, I'll just read out what the establishing part is. So the Universal Health Plan Governance Board, established in this bill, shall create a comprehensive plan to finance and administer a universal health plan that is responsive to the needs and expectations of the residents of this state. And then it lays out a lot of different sort of points that have to be taken into consideration and then have to be evaluated as this this plan is being created in order to be responsive to the needs and expectations. We talked a little bit about those last week, but I wanted to point out that this is a pretty broad scope in terms of what the legislation laid out. In other parts of the bill, it talks about the fact that the board has to consider the recommendations of the task force, to adopt the principles and values that are set out in the legislation. But the scope of what the board is here to create in terms of looking at a universal health plan is a fairly broad scope. And so I wanted to see if there were any follow-up questions on talking about the scope of the board, anywhere that we could drill down a little bit better to make sure that everybody has a really robust understanding. Sure, Warren, go ahead.
I went through this this morning and looking at it, and of course the lead paragraph, it talks about we shall create a comprehensive plan to finance and administer, which suggests, and in the task force, this was spelled out a little more clearly that we weren't really there to mess with care delivery. Mess is a wrong word. I wish I could use it, use a different one. We were concentrating on finance, but when you actually read this, there are some things in there focusing on coverage of evidence based care and services, I think as determined by this board. And that delves into straight into delivery issues that I'm not sure are really, it's a black hole that I worry about falling into. And I think, but some of our principles, I think, could deal with this. I'm not sure it's our intent to edict what care people can or cannot get, so much is that it's our interest in making sure that patients can be informed and have choices.
John.
Yes, on this slide, I noticed the item D, providing equitable access to person-centered care. And this particular statement is something that's actually motivated my initial concern about the principle of distributive justice, because equitable access can be defined in many ways. And how will we, the board, try to operationalize it in selecting which definition of equitable access that will be applied under this universal health plan. So for example, in my last board meeting presentation, I mentioned some of the popular common use definition of equitable access. One is equal access for everyone, but that operationalize is problematic because there are people who don't need the particular care, they don't need equal access. So the second one is probably the most popular one, called equal access for equal need, meaning everyone who have the same need of particular healthcare should have equal access. And then the third one is largely practiced by the UK National Health Services, which will be problematic for us. The third one is equal access for equal ability to benefit. So that has a discriminatory built-in into that. So these are just three popular examples. And so I think if we want to implement that equitable access, we need to operationalize it, which definition, which standard we will use.
And Dr. Chi, I think that once we get into the overarching principles discussion, something that Michelle had brought up last week was around the Oregon Health Authority's Health Equity Committee and their definition. And we have included that in a little bit later in the slides when we talk about fair distribution. Maybe we could have a conversation based in what you're talking about how we're defining equal access in terms of that definition when we get to that section. Because I think that maybe that can have a little bit of help for the board in framing how the board or how this work group wants to define it in terms of recommending a definition to the board. Does that sound okay?
Yes, and then I also have another comment on item H. Establishing, maybe we can also discuss that later, establishing measurable healthcare goals. And last week, when we met, we discussed that the quality has been banned in Oregon. So we may need to find an alternative measurement of health goals.
And I think that you're absolutely right. And I did include that and some information about the bill that Amy had mentioned last week. And I think that it's important for us to remember as we're looking at the principles and values that this work group is establishing is we can make recommendations to the board on how we might operationalize the values and principles, but for the purposes of the work group, we really want to be able to bring forward what are those values and principles that we want the board to look at, and then have an open discussion with the board about how we'd like to operationalize some of those values and principles. And that might be part of our operations plan moving forward, or be part of some of the other work planning that we're doing as we get into some of the discrete parts of the plan moving forward. But that is included, and we can have a conversation about that topic as well. So Katie, I think you can move on to the next slide. And that's where we're going to get into those overarching principal branches. And so last week, the group did come to a consensus around looking at these three sort of overarching principles. And in a conversation that I have with Warren, he gave me some insight into how he kind of viewed them as branches. And so I'm going to turn it over to Warren to sort of walk through and facilitate this part of the conversation.
Thank you, Jenny. And I'd really like to acknowledge the contribution of Chunwei in his work that makes some of this fairly easy to reach consensus on. The wording of these we might talk about a little bit later, but we're talking about health maximization, fair distribution of medical resources, and trying to at least minimize poverty. But before we get into each of these individual topics, I really wanted to ask the group if they had come up with any more. And Katie, if you could go to the next slide. These are in there just as a kind of to stimulate thinking. I think those three kind of miss something. I mean, if we just say eliminate poverty, maximize healthcare, and everybody gets everything, we may outrun community resources. So for me, there is a fourth. There is a fourth one, and I don't really know what to call it, but it is could look at it as stewardship of community resources. I mean, it is the way that communities will need to put some sort of limit, but I'd like, that's what I came up with. I'd like feedback from others. Chunwei.
Thank you, Warren. I think, in my opinion, we can refine the language, but principles are also very important. In terms of community stewardship, we can further refine the language, such as something related to sustainability, both political sustainability and financial sustainability. And then the fifth one, patient voice, is extremely important. As I mentioned, in many of the document, the World Health Organization promoted for universal health coverage. One very important tenet of universal health coverage is governance, meaning who makes the key decisions. And the term governance will include the patient voice, not just the patient, but the Oregonian's voice.
So would you call a fourth one, a fourth principle governance? Is that the principle that you think is there?
Yes, governance is a very important principle because it lay out once we, both in the process of building up this universal health plan, but also once we implement that in the future, how shall the system be governed, in particularly how we involve the Oregonian's voice? It's beyond just patient, but the general population's voice. And then what you mentioned about the stewardship, it has to do with sustainability. And again, we can refine what would be the appropriate word. And so in my opinion, is both are important principles to include. They are separate but important.
Amy, Michelle, Debbie?
What do we, oh, go ahead, Michelle, sorry.
Michelle?
I have a question running through my head and I'm struggling to frame it. I was listening to the Oregon Health Policy Board discussion yesterday about the attempt in Oregon to contain costs in our healthcare system to 3.4% annually in terms of cost growth. And the elephant in the room that was discussed at one point was the fact that the American healthcare system's primary goal, if you were to look at its actual outcomes, seems to be to generate profits year after year. And that it inadvertently or indirectly contributes to a lot of the other inefficiencies and negative health outcomes that we have in our healthcare system. And so my question is, I don't see a principle of returning record profits every year. That's not something we're discussing. But I guess my question is, since that is the momentum and has been one of the primary functions of the American healthcare system, is there something that we are not considering? Is there something we need to put in place here to ensure that that does not interfere with these principles that we are articulating? Because I think it's such a powerful force and it's so invisibilized in our healthcare system. So I guess my question is, are we doing enough to protect these principles? Is there something else that we need to consider that would counterbalance that powerful force? That's what I'm struggling with, and I'm not sure what that is.
Thanks, Michelle. Debbie?
How about now? Okay.
Yes.
Just so you know, I'm trying to toggle my settings. It seems like when I get my mic to work, my audio cuts. So trying to troubleshoot that. So I apologize. But one thing I would just add, and I think maybe this is already kind of inherent or embedded within the process, but also speaks to that kind of community engagement piece and public opinion, is also just transparency to the process itself and ongoing transparency. So I know it's kind of already embedded, but I don't think it hurts to call that out in some way, or whether that's a subcategory.
Thank you, Debbie. Amy?
Yeah, I agree with both what Michelle and Debbie said, and just wanted to kind of get further clarification about what do we mean about community stewardship? Is that the same as our community engagement efforts? What do we mean about patient voice? Like just making sure that we all, you know, mean the same things if we intend to add these.
And speaking for myself, I think to me an important thing is kind of in governance. I worry about a little because we have come to think, I think many people have come to think of government as something distant and not us. And so I like the word community better, and whether that's community governance or you know, the ability of the community to set up a system that takes inefficiency out of the system, I think is really important to our work. And I think that's a community sustainability issue if we don't have a better name for it. Chenwei.
Thank you, Warren. The word I suggested was not government, it's governance. And so you suggested community governance. I think that's an appropriate word. And one of the issues we may consider is also what Michelle mentioned about the concern, how to prevent the profit motives to interfere with our principles. That's also can be part of the governance, also can be part of the other principle I suggest that we consider is sustainability. That sustainability as an overarching principle, of course, just like the other previous three principles, they need to refine all the details to operationalize. But in terms of the general principle, we only need a very overarching words and principles, which later we will also give them operationalization. So the two I suggested, one's related to what Warren said, community governance. That involves community voice, how we give Oregonian voice in terms of how can we continuously improve the whole systems as well as responsive to the Oregonians' concern. But then the other issue related to Michelle's concern is it can be built into the governance, but probably, in my opinion, better to separate that as an overarching principle of sustainability. And more specifically, the sustainability relate to at least two dimensions, the financial sustainability and political sustainability.
Michelle.
Thank you. I like these themes that are emerging, and I think sustainability, I mean, at least the way I interpreted what you were saying, Dr. Chi and Chairperson George, it's really connected to this community stewardship. And I guess I'm wondering if, as we talk about sustainability, as we talk about governance and stewardship, making it clear that we do want sustainability over time for the program as a whole, both politically and financially. And also, when we talk about stewardship of collective resources, that we are explicit about wanting to balance access with sustainability. This came up again yesterday when we talked about how one way to contain cost is to reduce services. When you have more utilization of behavioral health, for example, you have costs go up. So I think I want to be really clear when we say sustainability and good governance and good stewardship of collective resources, that we want to balance that with access to, with these other principles, just so that it's clear, 20 years from now, when there are different people on the board, what we meant by that.
And speaking again for myself, I think, and if we call it community governance, I think that is kind of implied in some of that that we do have to allow for some kind of balance of priorities, using the community resource pool, and respecting that healthcare isn't the only thing that we need to do with that. So how does behavioral health fit as a priority against higher education? Or these are things that the state needs to balance, and I'm not sure we always do a perfect job of it. If there is no other discussion, how does the group feel about adding a fourth principle? And for now, we could just call that community governance, but it would include the concepts of state sustainability, community priorities, and actually include probably things like how are the resources gathered or distributed? How are the costs distributed in the community? So is there consensus on adding a fourth, Amy?
Oh, I was just wondering, is that also where transparency would fall under?
I think that would be under community governance as well. Anybody else? Chenwei.
Yes, I just responding to Amy's concern. Yes, transparency is part of the governance. Both transparency and accountability, they are all part of the governance.
Okay.
So I just want to do a little summary to make sure that we're getting this correctly, and hopefully Katie is also getting this, is that we're looking at a shared principle around community governance that would include a sustainable balance of access with collective resources through transparency and community input.
Yeah, for me, I think that instead of that being one sentence, it's kind of separate bullets. We're looking at balancing use of community resources. We're looking at sustainability, and we're looking at transparency and accountability. Each of those is kind of a separate bullet. That's
And
the way
access.
yes.
Okay.
So, Chenwei.
Part of the community ownership, the bullet point, I suggest instead of community input, how about considering a stronger word, which I suggested last week, a community ownership. Because the core issue is we want Oregonian to feel everyone have the ownership of this plan, and instead of thinking it's a top-down plan.
Yes, I think that is that's a very good word. Not sure where would you put it?
One of the bullet point under the community governance. Earlier you mentioned about several bullet points from what Jennifer suggested, and so what I just suggested is one of the bullet point. The original language you suggested was community input, but I suggest using a stronger word called community ownership, and I will be more than happy to share with the board the article I published with my co-authors, which was the introduction of this concept, community ownership.
I think that's excellent. I would hope that ownership would be maybe even part of community governance and ownership, or community ownership and governance. I mean, the ownership is very important, I think. It either belongs in the top bullet, we can figure out some of the wording later, but
Yes.
it
The-
sounds like we're getting close to consensus that on a fourth principle. So could I see by fist of 5 if we got support for this? Okay, looks like we've got support for that additional principle. And we will come back to this. I think we've got some really good concepts in there. But for now, I'd like to go back and look at the 4 major principles, and I kind of think of them almost like branches on a tree that we hang ornaments on. But let's start with promoting health maximization and what that means. Last meeting, we stumbled over measures of quality or DALI, and we weren't getting very far. A concept that came up that seemed to resonate more is that each individual should have the be able to make an informed decision on their care without other obstacles like cost or you know, I don't want to make decisions for patients, and I don't actually want doctors making decisions for patients, or I don't want the state system making decisions. To me, I guess the rather than having a specific measurement of life expectancy, or I think to me it's about a patient ability to all patients having an ability to make an informed decision. So what kind of feedback can I get on that? Debbie.
How about now?
Great.
Yeah? Okay.
Yeah.
Just toggling my settings in real time. So I think what you're speaking to with regard to patient decision making is something called shared decision making, which is ideally a part of the patient clinician relationship where you go over the available options. But I do think there needs to be some kind of measure of what those options are. I know that QALY is banned from being used, and that was recently passed in Oregon. I did do some digging, try and figure out what alternatives there were. And I did come across a National Council on Disability policy brief on alternatives to using QALY for cost-effective analysis. And they mentioned a lot of options that I'm happy to get into, but ultimately, I think some of them were theoretical. Many of them had limitations. So I can rattle them off real quick, but I am interested in Dr. Chi's expertise on any of these. So one was equal value of life years gained. One was health years in total, which incorporated a modified QALY, efficiency frontier, generalized risk adjusted cost effectiveness, burden augmented by deadliness and impact. And then they kind of went on to talk about multi-criteria decision analysis, which at present does incorporate QALY, which may be an issue, and several frameworks with regarding to individual values like shared decision-making and patient preference. So I think absolutely shared decision-making is an important aspect, but I do, in my mind at least, think of some of these as two separate things. And I couldn't find what OHP is actually planning to do as an alternative to QALY. I know this policy change has been years, decades in the making, but that it only recently passed. So if anybody has additional insight into that, I would love.
Thanks, Debbie. Amy.
I was gonna ask Debbie if you can send that to Katie or Jennifer so that we can all get that information to kind of look on our own. And I will continue to try to reach out to Disability Rights Oregon because I'm sure they are involved in the implementation of the changes or have some opinions in terms of the OHP no longer using Quali, and try to get some information about what they know about that.
Chenwei.
Yes, one of the challenge we have after the legislature banned Quali is the very reason Quali was developed in 1979 to 1980 was researchers tried to find a common indicator that allow us to compare across diseases, because otherwise preventing diabetes versus preventing heart attack, they are different apple and oranges. They cannot be compared. And so the important function of Quali is allow us to compare all apple and oranges across the board of all health conditions. But now the legislature took that away. It leaves us very few available measurement we can compare across conditions, because you just cannot simply compare prevention of heart attack versus prevention of diabetes. They are apple and oranges. And Debbie talked about life years. Actually, quality adjusted life years was based on life years to refine it. And the difference is for life years saved, we just ignore what kind of life years. So for example, when considering priority of any new treatment or any existing treatment, let's say treatment A, recover patient to full health. Treatment B, on a different condition, help treat the patient, survive, but patient will be bedridden for the rest of life. And then we treat both life year again equally. And of course, this is a value judgment that it's up to the public to see which preference we want. And there is, so to replace quality, we have to think multiple measurements, because there's no single measurement can replace quality. So among those multiple measurements, besides life years, one in the last 2 decades become very popular across OECD countries, the high-income countries, in comparing the effectiveness of each country's healthcare system. And this indicator is the most sensitive one. That is preventable death, meaning how the health system prevent any preventable deaths. The preventable deaths resulting from 2 issues. One is prevention. The other is treatable conditions. That if patient died from treatable conditions, and that's a negative point to the health system, because the patient shouldn't have died when that particular condition we have cure or treatment. And so one of the indicators I suggest we consider, among many others, is the health maximization include preventable death. We want to minimize preventable death.
Thank you, Chenwei. Amy?
I just want to state one of the reasons that Quali was discriminatory is that, for example, autism is not a disease, it's a neurotype. And it was one of the ones that gave one metric based on a diagnosis of autism spectrum disorder. And someone with autism may have co-occurring medical issues or mental health issues, often mental health issues due to ableism in our society because of discrimination against that neurotype. And so you can't compare every autistic human in the world, you know, was getting a number assigned, and then if they had co-occurring things would have also others. So I mean, it's when you have a mix of things that are not necessarily diseases in there, then you know, that is a big part of why it was deemed discriminatory.
It sounds to me like that what we're really looking for here may be input from the people of Oregon when we're another or a community, either in the form of surveys or citizen jury. And I think that could be one of our recommendations. Michelle.
I agree with the importance of input throughout ongoing from Oregonians. I do think that there's both, whether we're talking about government, the governance entity, or a broad survey of Oregonians, I think that we have to account for the bias that we all have in whatever process we come up with. And that's what Amy, what I heard you just saying is that there was a bias that was included in the way that quality was implemented in Oregon, and that was the problem. And so, you know, I think surveys are great, and also they will replicate whatever biases we have in our population that's dominant in our culture. And I'm no exception, and, you know, neither is anyone else that we would survey. So I think I would just say that my hope is that we would recommend some process for accounting for or weighting against or training for implicit bias in whatever public whatever the community governance structure is, that it would include an explicit focus on implicit bias and reducing the role of implicit bias in decision making.
And quick clarification for you, Michelle. Do you believe that there are organizations that could help us frame public input in a way that where we're framing our questions or jury decisions that avoid bias? Do you believe that that's possible?
I believe, yes, I do. I believe that it can be minimized. I believe that it can be, when we're talking about the governance body, there are very good trainings. There's the Stanford tests, implicit bias tests, which I've taken several of. They're very eye-opening. So I think there's definitely things that can be implemented. You know, there's no perfect way to completely eliminate bias or guarantee there is no bias, but I think there are a lot of steps that can be implemented.
Thanks, that's heartening. Amy.
I'd want to check with Michelle on those implicit biases if they included ableism. Last week, my organization held a unpacking systemic ableism training / event, and I'm happy to share the recording with you all. But when we're talking about these issues that impact chronic disease and disability, we need to be talking about intersectionality and ableism, as well as racism and gender issues. Because that's kind of at the root of where these things end up being discriminatory. I also wonder about potentially, once we kind of have some thoughts about what we want to do or get input from people like Disability Rights Oregon or the Oregon Self-Advocacy Coalition, which is a group of self-advocates that have intellectual and developmental disabilities and other conditions, that I think it's really important that we get feedback from these groups along the way, so that we don't get too far down the track and then realize, you know, that we're recreating another quality situation.
Thank you, Chun-Wei.
Yes, just to respond to Michelle's concerning comment, in terms of obtaining Oregonians' value and preference, after all, priority setting, such as which health measurement we want to maximize, is a value judgment. And for value judgment, there is no expert. In a democracy, the value judgment should come from the people. And that's one of the essence of community ownership. And in terms of concern about bias, among many methods of soliciting public values, I think citizen jury is one of the best methods to minimize bias because citizen jury allow participants to first hear expert comment on the related issue. So they are informed. They are not uninformed. They're making decision informed. But then the most important process after the expert commentary is the deliberation among the juries. And the jury should represent all aspects of the population. And the ideal end output of a citizen jury is come to a consensus. Because in a citizen jury process, the jurors, they hear all sides of the opinion. And in the end, they have to compromise to reach a consensus. So it's unlike survey, you have the majority voice dominated in any survey. But in citizen jury, the ideal is reach a complete or near consensus. So that's a process, one of the best process to minimize bias.
Michelle, if you could wait just a second, I want to check with Jenny if she has a process question.
I think that this is a really spectacular conversation, but I think we're getting a little bit into the operational side of how we would look at these values and principles instead of sort of staying with what are the values and principles. I think this conversation is going to be a conversation that the whole board is going to want to have around promoting health maximization. And so I'm hearing like the possibility of another principle coming out through health maximization that includes something about valuing intersectionality or promoting intersectionality in terms of community voice. And I just want to make sure that we're staying at that high level of trying to get our principle recommendations and not getting too much into how we would actually, as a full board and coming together with a plan, evaluate the principles and try to operationalize them. And so I think the conversation is very robust around this, but I want to make sure that we're staying with the principles so that some of these conversations can go to the board too.
Thanks, Jenny. Michelle.
Yes, thank you for that corrective, Jenny. I guess a couple of things. One, just quickly, Dr. Chia, I love the way that you laid out a citizen jury. I would still hope that a sub bullet point under promote health maximization would be account for and mitigate the role of bias. Like, I just think that needs to be part of this moving forward. And I would hope that citizen jury members would get anti-bias training. And I would hope that board members would get anti-bias training. I also wanted to correct myself. I misspoke, or I actually just said something that was incorrect. I said it was Stanford, it's Harvard. So harvard.edu has bias tests that people can take, and they do include disability, to answer your question, Amy. And I've taken many of them, and they're a great tool for just self-awareness. And then I think that finally, just in terms of the community survey not relating to bias, my understanding is that that's how we got to the flawed quality in Oregon, is that it was based on a community survey in another country. So I do think that in all of these processes, whether it's consensus or a survey, I do think that bias just needs to be accounted for. And I think that ties back to the Oregon Health Authority definition of health equity, which is, recognizing and rectifying historical injustices. Those injustices get embedded in our culture and in our the way that we're all socialized, and it's just how humans work. So that's the last thing I'll say about that.
And yes, and the definition we're about to go over says historical and current.
Well, it sounds like we are near consensus on that. One of our recommendation on measurement is actually recommending a survey or citizen jury, and I think the full board can discuss the difference. I am being swayed by Chunwei to be very much in favor of citizen juries, but I'd like to hear what the full board says on. So if we got more or less consensus on that as a recommendation of using community engagement, probably in the form of citizen jury, to look at measurement, establish of measurements. You there, Amy? Okay. Oh, Chunwei, did you have anything to add to that?
Yes, before we move to the next principle, there is one other important issue I'm not suggesting we discuss now, but the full board should discuss. That is besides the health measurement that we are going to develop or identify for health maximization. Another issue is whose health are we maximizing? And that is an important and complex issues that I think require the full board discussion. And I'm not suggesting we discuss it now because, for example, we could say we want to maximize everyone's health, which is operationally very challenging. The other example would be if we want to bridge the health inequity, then one of the target of maximization health will be the people whose health are way below the average population health. And this is just an example to illustrate this is a complex issue. Besides the measuring health, another important issue that needs a full board discussion is whose health are we going to maximize?
Thank you. And that was it. Thank you, Chunwei. That leads me into where I was going to go next. Segue. I want to go back to the importance of the individual making, to me, the measure of health maximization is when the patient is happiest and has fewest obstacles. So I would certainly favor, and we could, test this in some sort of citizen jury, the power of the individual to make choices rather than make informed choices. And without impediments. And part of what that means to me, we have to figure out how to operationalize some of these things. But I think particularly, we can maximize health by making a priority for prevention, obviously, things like childhood vaccines. But also, I hear about lots of people who don't get cancer screenings in a timely manner because they don't have only, I don't know what percentage, but it could be as low as 80% of people actually have a primary care physician. So I think doing, anything that we do to make prevention and screening available without intimidation, without having to go through someone else. I think those are examples of ways that we can use policy to maximize health. So wanted to see if anybody had any comment about that line of thinking as far as health maximization. So if not, I will make an additional point that's important to me is when I talked about individual decision, I think we also need to bear in mind in cases of public contagion that we do need stronger unified decision-making by whatever name that you call that, for instance, ability of public health departments to take action. So let's move on to the next principle of fair distribution. And one of the things that came up last meeting, Jenny, could I ask you to just go ahead and review this slide for us, please?
Do you want me to go ahead and read the definition?
Yes.
For the conversation? Sure. And so I think it was Michelle that brought this to us last week. And so the Health Equity Committee, which is a subcommittee of the Oregon Health Policy Board, came to the following definition on health equity, which is that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other social determined circumstances. So the bullets are achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices.
Thank you. Is there any discussion on this as a statement? And I would say I would be in favor of adopting this as just a kind of a statement that goes in there. So well, Chunwei, do you want to discuss?
Not necessarily a discussion during this time, but I fully support and agree this principle. At the same time, there's one issue remaining that requires a full board discussion or elaboration. That is the second bullet point, the equitable distribution. That the term equitable need operationalized. Again, there is not just one definition of what is equitable. There are multiple, even dozens. Theoretically, there are dozens of different definitions of what is equitable, and that has a profound implication on the policy. So I suggest when we support, we adopt and support this principle, but that what definition of equitable we are going to use require further discussion of the full board.
Thank you, Chunwei. And for me, I see us adopting this, saying that we agree and support this, but this alone is not the full, that all of the things, Chunwei, that you said, how is it equal access, or is it equal access based on ability to improve? I mean, there is equitable distribution is a separate thing for us to determine. And I like the idea of a citizen jury to weigh in on those things. And I think with your help, we could get a program to put in front of a citizen jury that fairly poses the questions for them to consider. So I think there's, Michelle.
Sorry, I was just getting in stack. I don't want to interrupt your thought. Did you want to complete what you were saying?
No, go ahead.
Okay. I just wanted to add that this was developed by the Health Equity Committee, which is a subcommittee of the Oregon Health Policy Board. But my understanding is that this has been adopted by the OHA as an entire agency and does guide their work as a state agency. And so I just think that's helpful context. And I fully agree. I'm also in support of adopting it as a guiding principle for us. And then of course, needing to refine and operationalize the term equitable, as Dr. Chi mentioned. So just wanted to add that context.
Anybody else? So first, let's show support for the statement. I think we have it from everybody. So yes, we've got fives all around. And then I think the secondary issue of fair distribution, we might refer to as citizen jury. And by the way, I had asked Jenny to put this slide together because I think some people may not be familiar with the term citizen jury. I know I wasn't until I began reading Chunwei's materials. I hadn't heard or actually seen that used. Jenny, could you just review this slide for us?
Sure. And just so you all know, I took this from one of the papers that Dr. Chi provided to us in the May 16th meeting that he is a co-author on. And so the definition that's provided there is a group-based deliberative method based on the model of a trial jury. A jury of representative community members from different backgrounds hears data and other evidence presented by a range of experts on a policy question. The jury can ask questions of these expert witnesses and engages in a group discussion to evaluate which choices are best for their community in order to arrive at a consensus recommendation.
Is there any comment or question on this, Chunwei?
Yes, I just want to make a further comment, which I think we included in the article, but not in this excerpt, is compared with the popular conventional survey method. The survey method put individual as an individual because that's how the individual respond to survey questions. But so that's a survey method is both philosophical and methodological individualism. The citizen jury is both methodological and philosophical communitarianism, meaning when the jurors, they are engaged in deliberation, they are no longer consider themselves as pure individual. They consider themselves as both as an individual, but also as a member of the community because they have the opportunity to hear any bias, any opposing opinions. So that not only hearing the opinion, but people who raise opposing opinions need to deliberate why they hold that opinion. And so that facilitates more understanding, more communication, and which is why it has the potential to minimize bias and also accommodate minority voice.
Thank you, Chunwei. As I read this, one of the things that I consider, and I like the word community because it's something that I can get my head around. I think the more local I put problems, the easier it is for me to come up with rational solutions. But what level of community are we talking about? At a county level? Are we talking about a regional level? Are we talking about a state level? And how much difference can we deal with between regions? Anybody have any comment on that? Chunwei.
There are different approach. Again, this may require the full board to decide and to discuss. One example was in 2012, the South Korea, they have a national citizen jury. So South Korea has over 50 million population. Still, they were able to there are two-stage selection. The first stage is volunteer. So in their first stage, they got over 1,000 volunteer. And then the second stage is you random selection, but the random selection is not purely random because you need to have those jurors representing every aspect from ethnic, age, gender, value, and region. And so the randomized selection from the volunteer resulted in about a little bit over 20. The 20 should have a intersection of representing all dimension of the population. So that's one example that one potentially we can have a jury representing all Oregonians. The other option is having regional citizen juries that represent both urban, region, and rural area. So again, those details we can discuss in the full board.
Chunwei, Amy.
I'm wondering if if Dr. Chi, if you have access to information about citizen juries being used in countries that are multicultural, such as the United States, you know, that are less homogenous as some of the countries, you know, that we're looking at as examples, and how this plays out in a more diverse, multicultural country or setting.
One of the pioneer of applying citizens jury in public health policy was Professor Gavamuni in Australia. And he conducted a citizens jury including both the mainstream residents of Australia, but also the long-term suppressed the indigenous Australians. And many of his examples, I can share those references, were able to accommodate the minority voice, particularly the long-term history of being colonized, being oppressed, the indigenous Australians. Through citizens jury, their voice were heard in that process. So I can find some of those references.
Thank you. And I guess what I would add to that is, and in our system and America is designed, we do have, using the analogy of law, which is, and the Constitution to protect, let's say, minority interest. It hasn't always worked out the way it should, but it's at least an ideal, and I see that same principle. I think there may be ways for bias to sneak into some of the citizen juries, but I think the general statement about equity is our protection that says those are absolutes and we won't. You know, there are some things out that are out of limit. They're out of bounds, but they're, and as long as we can identify those, then citizens can operate. I mean, the citizen juries would have some freedom to operate on some of the things that don't violate those. Debbie.
Okay, I think I figured out my mic. Can you hear me? Perfect. All right. So I wonder if we are getting a little bit into the weeds as we did before, and if we're looking for maybe more of just a kind of more definition way of thinking of this. And I did like the idea, Dr. Chi, that you brought up last time I watched the recording of kind of having like working document that can go back and be refined as we continue to explore some of these more nuanced areas. But one comment I do want is just kind of, you know, we're using societal resources, and those should be based off, you know, societal preferences, but also balancing that with not deferring to the dominant culture, because that goes contrary to what we're trying to do with health equity. So I think this sounds like goes into speaking of how we choose to set up these citizens juries, but I do wonder if maybe we're needing to kind of think of this more in terms of a broader definition as opposed to getting into those details.
Thank you, Debbie. And to me, I think, you know, the real question is how good of a job can we do? I mean, how much expertise can we bring to doing a really good job of the citizen jury? And in the state of Oregon, and you know, it will require a certain amount of minding the pot on our part to make sure it's headed in the right direction. But I feel like it will require some specific expertise in this area. And I'm wondering if Chunwei can give us examples of citizen juries in the Northwest or in Oregon, or in a similar area that I know they've tackled this, I think, in Chile and some other places, but what kind of what confidence do we have that we can put this together in Oregon?
Yes, I will search to see whether any organization, not necessarily in health, I doubt it ever done in health. Any organization have used a citizens jury in Oregon. The method is still relatively new, that even within public health, most people are not aware of that.
But do we have group consensus that our recommendation for board consideration is that when we're talking about distribution, that we make use of a citizen jury or similar means of public input as a recommendation? You with us, Amy? Okay, thank you. So next slide, please.
If I could, I just want to go back for a second to what Debbie said. And I think that she was going in a direction that I've been thinking too. And that is there, it sounds like the board is coming to, around this conversation, the idea of a principle around something relating to mitigating bias. And I don't want to lose the thread on the idea that there could be a principle that might want to evolve from the conversation around like how the board, not just, I think we're talking about the operationalization of it a little bit in terms of looking at the citizen jury and talking about bias training for any citizen jury members. But it sounds like there's a little bit of consensus for the members here around like what Michelle said for accounting for and mitigating the role of bias in either plan design or deliberations or in decision making. And I'm wondering if that's something that the board, or I'm sorry, that the group would like to bring forward also as a possible principle, something around the idea of mitigating bias.
I guess the way that I would put it is that what we're really talking about is that our priorities of distribution must reflect community values and principles. I see Amy saying, but saying that with the provision that it cannot violate bias or our statement about equity. So I see some hands shooting in the air. So Amy.
I actually really liked how Jenny stated it, and I think it needs to be much more explicit and not wrapped underneath, but like a core principle. That's my opinion, but I'll hear what Michelle has to say.
Yeah, and I think, thank you, Jenny, for offering that. I also really like it as a principle because to me, it goes beyond any one process or component of governance. Like it's bigger than the citizen jury. It should apply to all decision making, including the governance board ourselves, in my mind. And so I'm getting a little, we're talking about high level principles. We're talking about a few sub bullet points. So I guess I was initially thinking of the anti-bias component as a sub bullet point. But I actually like it as a standalone principle because I think it is broader and it should apply to anywhere where decisions are being made. That principle should apply. We should at least pause and think through whether we're doing what can be done to account for and mitigate bias. So I would be in favor of having the group consider that as a standalone principle, as Jenny laid out.
And I'll just restate it because Michelle, it was actually the way that you stated it. But I'll add what you said there, which is account for and mitigate the role of bias in decision making. Does that sort of capture what you were thinking?
I think so. Yeah, is that yeah, what do you all think, group?
Can you say that one more time, Jennifer?
Sure. Account for and mitigate the role of bias in decision-making.
Yeah.
One thing that we could do is we have placed the state statement underneath one of the individual principles, and we could move it sort of in effect to the lead paragraph that says, when we look at these other principles, this will guide us, and the statement that Michelle just gave. I mean, we could pull it out of right now we have it under fair distribution, but arguably it could apply to health maximization and poverty issues and governance as community governance as well. So would that help if we moved it out of the interior and put it above the top line? Michelle.
That's a really interesting suggestion. I guess I would be in favor of, to me, there's a distinction between a definition and a principle. And so we're talking about principles. I think I would be in favor of, in addition to saying to the full board, in addition to these identified principles, whatever we come up with in the end, we also recommend that the board adopt the OHA health equity definition as a way of guiding our work moving forward. To me, they're distinct. I don't know how to think about putting a definition within a hierarchy of principles, because I think it's how we're thinking about health equity and some of our goals for this work. And so to me, it is overarching, like you said. It would apply to all of these principles potentially, but I guess I would separate it out a little bit as this came up in our discussion. It's a definition. We also recommend adoption of it, if that makes sense.
Yes, and what I see as we begin to lower our time, I do want to give people an opportunity to talk about the issue of minimizing poverty, but let's cover that, and then let's get back to how we're going to get this written out and approved next meeting. Does anybody have any comment about the issue of protection of poverty? And for me, I think we need to be careful about our wording. We cannot eliminate or protect against all poverty. What we're trying to do is minimize poverty, particularly poverty related to healthcare. And to me, I think there are two principles related to this. One is the principle of spreading risk across the community. The other is the principle of how we distribute the cost, which would be under the community governance issue. And those are two things that have yet to be determined. Do we have any quick comment on the minimized poverty issue? Chunwei.
Yes, thank you. Warren, I agree with you. The universal health plan is incapable and not the function or purpose to protection against poverty. So we need to be more specific. The protection against poverty due to healthcare costs, I think we need to be very specific, because it's not this universal health plan's business to eliminate poverty. So the language, I agree with Warren, has to be very specific. It's poverty due to healthcare costs.
Any other comment on this specific overarching principle? Okay. Oh, Michelle.
One question I have, just thinking about what we might need to have in place, regardless of what may or may not happen or be in place or change nationally. There have been a lot of challenges to the Affordable Care Act going before the Supreme Court over the last decade. And so you were talking about, how we distribute risk and cost. And I just wonder if we want something about, when we think about risk, something about protecting people with pre-existing conditions, or if the federal law were to be repealed or weakened in a significant way, that to me ties into how we think about risk and spreading risk. Because to me, that was one of the most important achievements of the Affordable Care Act, for all of its flaws, was that it disallowed that discrimination. And then I think protection against poverty, this is one of the challenges that I've seen with the Affordable Care Act is when you have a system, especially initially where everyone is essentially forced to participate on some level because of the way that we fund it through taxes, how we think about cost and what we mean by poverty. Poverty has a very specific definition. Are we talking about the federal definition of poverty? I think those are some of the questions that would need to go to the full board, because the Affordable Care Act maybe didn't force anyone directly into poverty, but it became the measures that were used, like the cost of a silver plan in your area, very quickly became inaccessible to most Americans. So I think this question is actually the definitions, however we land on definitions with the full board, I think that this is going to be a really important one. So I actually wonder, I'm curious if Dr. Chi or anyone has thoughts on, is poverty the right word? Or are we actually talking about significant financial hardship? Like, are we just talking about preventing medical bankruptcy? I guess is like my question. Thank
you, Michelle.
Michelle's last comment about medical bankruptcy was my question, was like, so I'll just let people respond to that.
Okay, so as we wrap up our meeting time here, if I could have next slide, please. By the end of next meeting, we want to have perfected our recommendations to the board on our overarching principles and how we achieve those. I'm going to propose that Jenny and I try to take everything that's been said and incorporate it into a document which we will circulate to each of you as board members that you can help with the wordsmithing. So, will you consider that, Chun-Wei?
Yes, just responding to both Michelle and Amy's comment about the wording of protection against poverty. It seems the word poverty may not be the best one for this principle, and we don't have to decide now, but by next week's meeting, we can finalize what the appropriate word to replace the word poverty. For one example is protection against financial hardship. That's just one of the potential options, and we can decide that next week.
Okay, Jenny, I have volunteered you for a significant amount of. So does that sound like a good way to get ready for next meeting?
I think that sounds great. I just want to go over, and just while we have everybody here before we send out a document, So what I have is that the recommendations we're looking at are to continue with the 3 overarching principles that we talked about in the first meeting in terms of maximizing health outcomes, fair distribution, and some wording of minimizing poverty or financial hardship, and also bringing forward another principle on accounting for bias. And then the group would like to recommend a citizen jury as a way to sort of, as a tool for operationalizing the principles and values that the group is coming to. Does everyone think that that's sort of what we captured in this meeting?
I think you left out the 4th principle of community governance.
Oh, I'm sorry.
Yeah, it's there. It's buried in your notes.
Thank you. And so you have
Michelle.
In addition, just another thing for that list was we had discussed, I don't think we've made a final, well, yes, we did do a fist of 5 on the bringing the health equity definition as a recommendation to the full board as well.
And I will add that. And I just want to throw out there to everyone now, I know we don't have a lot of time, but as we were having that conversation, I was wondering if maybe the health equity definition was less of a principle and more of a value, where it's something that the board is sort of committing to as part of its value system. Because some of what Michelle said about like, where do we put this definition in terms of the principles? How do we state a definition in principles? The definition might lend itself better to looking at it through the lens of value that the board might want to commit itself to. And so we'll put that, I'll include that in the document also for everyone to have a comment on.
I think that's an excellent point, Jenny. So I want to thank everybody for participation and putting up with my facilitation. And I think we've got a very good group, and I'm pleased with the product that we're able to put forward. So thank you.
Thank you, everyone. It's a great discussion.
Thank you, everyone.
Thank you.
Thanks.
See you next
Bye.
week at the same time.
Okay, thanks.
Thanks, everyone.
Jenny.
Thank you.